Hello everyone, welcome back to our NCLEX review series, and today we are inviting you to join with us to our interactive NCLEX R review session. So if you're new here, we are currently on day 27 of our complimentary 90-day NCLEX preparation series. So we are also inviting you to enroll in our dynamic NCLEX review course today at Stancoast NCLEX Coaching for personalized support tailored to your needs. Kindly visit www.stancoastnclexcoaching.com in order for you to engage in our informative lectures and also to tackle over 3,000 NCLEX questions through interactive learning. So we want you to discover about our 10-hour animated video course and enjoy flexible study sessions with 100 hours of preparation time, so you can enhance your confidence with our extensive on-demand video library and also practice exams. All right, let me adjust my volume. I hope that you can hear me better this time. Hello, can you hear me? Can you hear me this time? I'm wondering if you still can't. I have my full volume right now. How about the others? Can you hear me? Because actually I'm also launching the YouTube on my iPad and I can actually hear myself. All right, can anybody confirm that you can hear it? Okay. All right. All right, virtuous lady, probably get your volume checked out first. All right. Now, we're also going to have to do our NCLEX test questions today. We're going to go through some of the topics that we have already discussed. And so, again, we are inviting you to invite your friends and also spread the word to your fellow NCLEX candidates in order for them to enjoy our sessions for free, and make sure that you're also going to check out on our description box below for more details. And we always value your feedback, guys. So feel free to share your thoughts and questions in the comments. And also we'll be happy to clarify those topics that are quite unclear for you. And so again, we will be tackling some questions today about the respiratory concepts. So let's get started. And of course, I'm just doing today part 1 of 3 series of the test questions. So we're going to do more tomorrow and the following day. All right, let's get started. So we do have our first question here. It says, a female client with systemic lupus erythematosus has developed shrinking lung syndrome, is on a prescribed course of prednisone. What symptom might she experience if she abruptly discontinues the medication? All right, rereading the question right now. It says, a female client with systemic lupus erythematosus has developed shrinking lung syndrome, is on a prescribed course of prednisone. What symptom might she experience if she abruptly discontinues the medication? Is it A, hyperglycemia and glycosuria, or B, acute adrenocortical insufficiency, or C, gastrointestinal hemorrhage, or D, restlessness and seizures? I really want you to go through the options and also hang on a sec. Let me reposition my test question here because I don't think you can see the rest of it. Let me move it downwards. How about that? Okay. All right. So again, the question states, a female client with systemic lupus erythematosus has developed shrinking lung syndrome, is on a prescribed course of prednisone. What symptom might she experience if she abruptly discontinues the medication? Is it A, hyperglycemia and glycosuria? We have B, acute adrenocortical insufficiency, C, gastrointestinal hemorrhage, and D, we have restlessness and seizures. So looks like you are selecting DBB. All right, let's take a look. So we're gonna actually deal with this right now because our patient is taking prednisone, right? And we know that most of these patients, of course, with the lupus erythematosus, they're going to need the anti-inflammatory, the steroid medication, which is the prednisone, right? And this will decrease the inflammation in so many other systems that they have, okay? There's also, somebody answered letter A, okay? Now, the focus of the question here is asking what symptom might she experience if she abruptly discontinues the medication. All right. Guys, remember about that our body has its own source of the cortisol, right? Or the glucocorticoid that's produced in the adrenal cortex. And remember that when the person will be taking a source outside from the body, let's say a medication or prednisone, remember that it can cause suppression of the body's production of the glucocorticoid, right? And so that would be the clue here. So let's go through the options here. Letter A, hyperglycemia and glycosuria. Do you think that that is a symptom that may be experienced by the patient if they're going to discontinue abruptly? Hyperglycemia, it means that the patient's blood sugar will be going up, and also there will be glucose in the urine. And normally we don't see glucose in the urine, right? So that simply means that the body has too much sugar and now it's spilling into the urine. And the situation here is on a patient that is taking the prednisone. And it's telling us that if she discontinues the medication, what could possibly be the events that could follow? All right. So do you think A would be the answer? All right. Looks like majority of you guys have answered letter B. Well, letter A. Hyperglycemia and glycosuria is actually incorrect, right? So these are the common side effects of the prednisone when they are taking the medication, but not when they had abruptly taking the drug, okay? So please take note of that. The hyperglycemia and glycosuria are the side effects if the patient is currently taking the medication, not when they are abruptly discontinuing the medication, right? So we are eliminating letter A. X on that. All right. Nice try, though. All right, let's go to the next option. B, acute adrenocortical insufficiency. Well, sounds like correct to me as well. Remember about what I had said earlier, that when the body is getting outside source of a glucocorticoid, it can cause adrenocortical insufficiency, right? So it will stop producing its own glucocorticoid. So by the time when the patient is not taught well in the proper regimen, let's say they'll just discontinue all of a sudden, okay? They're not following through the instruction that they need to taper the dose as ordered, then if they just suddenly stop, then this can cause a problem with this name, adrenocortical insufficiency. Now, the abrupt stopping of taking this medication can really cause a considerable drop in the cortisol, okay? When this happens, guys, your patient, when they're gonna probably be undergoing some kind of a stressful event, maybe they're supposed to go for like a dental procedure, just that kind of procedure even is going to be stressful for them. They will not be able to tolerate this kind of procedure. They're going to end up with hypotension. Their blood sugar will start to go downhill. and they're going to panic, okay? Because they really need to have that safe amount of the cortisol or glucocorticoid in the body. Yes, Mary, you said prolonged usage of prednisone. That's correct. And this patient that has lupus erythematosus will be taking the prednisone for quite some time, not just about 2-3 weeks. No, most of these patients will be taking a long-term prednisolone or prednisone rather. And so when they're abruptly discontinue the medication, then this can lead to that issue, like similar to the Addisonian crisis, right? And so again, our role here as nurses is to make sure that they are they have understood the therapy, what should be done before they will discontinue taking the medication. Make sure that they follow through the schedule, okay? And they should be able to some kind of like do like a teach back or something like that, that they need to tell us what exactly they had understood for that teaching. All right, so make sure that we are sure that they understood those pharmacological instructions. Now, looking into, okay, so our answer here is letter B, of course, right? But we're going to have to continue looking into the rationales for the rest of them. So gastrointestinal hemorrhage, this is a side effect for the use of an oral glucocorticoid, especially prednisone, because this is highly irritating to the gastric mucosa. And of course, this is what we call as the medication has ulcerogenic property. It can cause peptic ulcer. So most of the time, when they are going to be given this kind of prednisone, they'll be taking some sort of like anti-ulcerant or antacid, or if in such a case that they might have a pre-existing peptic ulcer disease, or maybe some remote history of gastric acid reflux. They might need to have a prescription to prevent any ulceration. So maybe they're going to be using the PPI, the proton pump inhibitors, or could be the H2 receptor antagonist to prevent the recurrence of the gastritis or the peptic ulcer disease. All right. Now let's talk about letter D. So C is wrong, letter D. What about letter D? Restlessness and seizures. What's this? These are not common symptoms, and they are not associated with abruptly discontinuing the prednisones. And these are known to be associated with other conditions, or let's say withdrawal from other medications, but not closely tied, or they're not typical manifestations of prednisone withdrawal. So we're going to have to eliminate that one. Okay. So this is pretty much like a simple pharmacology question, right? So my advice for you, in order for you to answer this question in a very straightforward manner, I really want you to make sure that you recognize first the question, what it is asking, okay? And also, before you're going to look for the answers, make sure that you have to do that elimination process. You have to go through each option. Do not look for the answer right away. Make sure that you are focusing on those side effects, or let's say the manifestations. Are they really associated with a discontinuation or abrupt discontinuation of the prednisone? If not, eliminate them right away. So such as the A, hyperglycemia, glycosuria. Well, of course, they're not going to end up with a hyperglycemia, but the exact opposite, right? Hypoglycemia, none of that. Also, with the word here, abruptly discontinues, this is our clue, which simply means it's asking for the withdrawal manifestation, okay? So again, you have to really recall those fundamental information or basic knowledge about abruptly discontinuing the prednisone or any kind of steroid medication. All right. Now, also with the gastrointestinal hemorrhage right here, this is considered as a long-term kind of a potential side effect that may occur with prolonged use of the steroid, let's say the prednisone. It doesn't happen like within an instance, right? It doesn't really occur with an abrupt discontinuation. So you're also gonna eliminate that one, okay? All right, so I hope that you're able to get through that. We'll tackle the next item. But before we go to the next item, let me just adjust the screen because I just noticed that it's hidden behind the image. So let me just rearrange real quick. All right, give me a few, or maybe a minute here to quickly fix this. All right. Okay, almost there. And there's one more. Okay, let's have question number 2. All righty. Now the question states here, a patient with chronic obstructive pulmonary disease or COPD is prescribed Theophylline for the management of their condition. The healthcare provider emphasizes the importance of monitoring the patient's serum theophylline level to ensure therapeutic effectiveness and avoid toxicity. What is the therapeutic range for serum theophylline concentration? So this is basic pharmacology. We are getting tested here for the property of the medication and also the therapeutic level. Okay, so our option here, option A, 5 to 10 micrograms per ml, B, 2 to 5 micrograms per ml, C, 10 to 20 micrograms per ml, and D, 1 to 2 micrograms per ml. Are you still there, guys? All right, we have Dorje answering letter C. Adiola, all right, answered letter C as well. So guys, we're simply asked here about the therapeutic level, the safe range of the theophylline, which is a bronchodilator. Mary answered C as well. Hi, virtuous lady. Were you able to finally hear me? I hope so. All right. So, again, the situation is for this patient with a COPD, and the patient has a prescription for the theophylline. And again, this is going to be taken either PO or IV, but this is, it's not really specific here. It's not mentioned whether it's an IV or a PO. We're just simply ask the therapeutic range, the safe range of this medication. All right, let's answer right away. So the correct answer for this is letter C. That is 10 to 20 micrograms per ml. So the rest of the options here, A, B, and D, these are subtherapeutic levels. So this will not do any good for our patient. It's not gonna work. It will not exert any therapeutic effect into our patient. And the expected drug action for this medication is to cause bronchodilation, right? Because our patient is with a COPD. They're not gonna be able to breathe normally like we do. So there could be that obstruction in the airway, possibly because of increased mucus secretions, and also with the decreased lung recoil of the alveoli. Let's say, for example, if the patient has emphysema, right? Yeah, the correct answer is letter C. Now, the side effects, though, that we need to expect for this medication, let's just talk about the side effects right now, guys. The side effects will include the following. And so it can lead to irregular heartbeats, irregular heartbeat, and it can also lead to seizures. And when you're going to be the nurse taking care of this patient in the acute care setting, and you find yourself, you find this patient having a seizure episode or developing an arrhythmia, you definitely need to notify the medical provider right away, like stat. Make sure that you're addressing this. Seizure is no good to the brain. It can cause a whole lot of issues. And this simply means that the brain is not getting enough oxygen, right? And we don't want this to prolong. You want to make sure that your patient is kept safe. Of course, that would be our first intervention, just in case your patient goes into a seizure episode. Make sure that they are kept safe. And if they are found in their, let's say, bed, laying in bed and having that grand mal seizures, this is kind of terrifying though. Make sure that they're going to be kept on their lateral side or side lying position, and make sure that you have the rails up. And as much as possible, we can pad those side rails as much as we can. And we're going to have to time the seizure episode. Make sure that you have that information readily available in order for us to determine how long the seizure episode has occurred, okay? Because if it's going to go beyond, let's say, more than 5 minutes, yeah, there's a whole lot of complications that can occur. Brain anoxia, this can possibly lead to some permanent damage to the brain, and also there will be some end results, like, let's say, maybe some mental disorders, or not mental disorders, rather cognitive disorders could possibly result from the prolonged anoxia. So we don't want that, guys. So we definitely need to have that information, the start and the stop time regarding the seizure episode. Make sure that we're keeping the airway open, guys. That's one. And then want to make sure that we have a suction setup that is readily available. Actually, BNM, the question here is, any difference between the serum level when taken orally or IV? Actually, no. The route really doesn't matter if we are checking into the range. The range is not dependent on the route we're giving the medication. So it's just basically the therapeutic range, the amount of available medication in the bloodstream. It doesn't really going to depend on whether it's IV or PO route. Okay. Now going back into the seizure, guys, make sure that you are keeping the patient safe. That's one. Make sure that their airway is maintained. If there's a need for us to suction the oral secretions, we got to do that. And if there is a drop in the oxygenation, we want to make sure that we are giving them the oxygen in order to prevent more hypoxemia. We want to treat the hypoxemia. And of course, if the seizure episode is extended, of course, you can always ask for help. You can yell out and get some help from anybody, an RN maybe, to call the medical provider around this time. If there is no PRN dose of, let's say, diazepam or any sedative medications or benzodiazepine, then make sure that we are going to have to get that order in order to delay, or not to delay, but to discontinue the seizure episode. Okay. Now, as we are talking about the seizure here as a adverse reaction or the side effect of the theophylline, I almost forgot here. The irregular heartbeat is also one of the side effects, and this is something that we can deal with the administration of the lidocaine, okay, IV, in order to stop the arrhythmia. Okay, so your patient needs to be placed on a cardiac monitoring continuously to make sure that we are able to capture any life-threatening dysrhythmias. So that's one of the other interventions that we can do for this patient. Okay, now again, please don't forget, guys, the role of the theophylline. This is basically going to what? Cause bronchodilation. Again, as I have said before, the theophylline use is not as popular nowadays because of these side effects. And of course, with the discovery of the newer medications, then they are much used compared to this one. All right. But just in case, in some cases, the medical provider will still order. At least you have an idea how to deal this kind of medication. All right. Now, the other reason that this medication is somewhat kind of like, we have to be really cautious, guys, because with the medication itself, if it's not monitored properly, then it can raise the epinephrine and norepinephrine. Please take note of this. It can raise both norepinephrine and epinephrine. And these neurotransmitters can do a whole lot of things, especially in the receptors, right? That's why it's really going to cause that irregular heartbeat. And in some point, though, at some point, this can also lead to metabolic acidosis. That's another possible complication of the theophylline therapy. Metabolic acidosis. Hang on. Metabolic acidosis. And also it can lead to hyperglycemia. So these are the other known effects of the theophylline, and also a drop in the potassium level. So aside from the irregular heartbeat and also the seizure, our patient can potentially have metabolic acidosis from this medication if we are not monitoring the therapeutic level. Also, an elevation of the blood sugar and a drop in the potassium level. Hypokalemia. So don't forget this other side effects. Now the question was, how does inhibiting phosphodiesterase aid and the med to work? Okay. Well, the medication itself will inhibit the phosphodiesterase, which is actually the enzyme, which is actually going to be inhibited at a higher dose. And so this will increase the CAMP and also activate the adrenergic responses. And so this can also lead to the catecholamine release. I have exam on June 26th. Would you tell me about important topic? Dorje, I'm not quite sure if I understood your question. Are you asking if we about the succeeding topics that will be conducted in our review? Okay. And so, guys, with that, the effect of the aminophylline, this can also lead to, this can really prevent the phosphodiesterase, and it can also, it will really definitely cause that bronchodilatory effect, right? When there is increase in the CAMP. All right, let's move forward here with the next question. It says here, in an emergency room with a case of acute pulmonary edema, a male patient suddenly sits up, experiencing dyspnea and an oxygen saturation of 85%. Which oxygen delivery method would best alleviate these symptoms? Is it A, simple mask, B, nasal cannula, C, non-rebreather mask, or D, face tent? Again, the question says, in an emergency room with a case of acute pulmonary edema, a male patient suddenly sits up, experiencing dyspnea and an oxygen saturation of 85%. Which oxygen delivery method would best alleviate these symptoms? Is it A, simple mask, B, nasal cannula, C, non-rebreather mask, D, face stent? Looks like Mary answered C. Boss Babe, is it how you say your name? And Dorje answered C, non-rebreather mask. All right. So our case here is on a patient with acute pulmonary edema, a life-threatening condition. And this is a complication that can occur as a result to probably a pre-existing left-sided heart failure. And so if there is an overwhelming amount of fluid circulating in the bloodstream, this can lead to backflow of blood from the left chambers of the heart into the pulmonary circulation. It can lead into congestion of the pulmonary blood vessels. So they're going to end up with that difficulty of breathing that is so pronounced that they cannot tolerate just breathing on 45 degrees. They need to sit upright in order to catch their breath. And take note about the 85% saturation. That is very low, okay? So what would be your course of action here, knowing that this is a severe form of hypoxemia? Your patient is in an air hunger mode. Your answers are all correct, guys. You answered letter C, which is non-rebreather mask. That is the best answer. We don't want to go through the levels, like starting with the low flow. We already know the patient is having difficulty of breathing. And we already have the information about the saturation of 85%. We already have that. Unless if we don't have a kind of information, then we're probably going to start with the low flow. But the patient already has a known diagnosis of pulmonary edema, and they have that dyspnea already with 85%. So you have the important data already. And so the non-rebreather mask can deliver high flow oxygen at what rate? It can give us about 100% of oxygen when we are delivering it from about 10 to 15 liters per minute, okay? So that is the most appropriate way of delivery system for this patient. Well, of course, the severe dyspnea need to be reversed at this point, okay? We want to make sure that our patient is getting the maximum possible oxygen delivery, and make sure that we are going to have to use the correct mask, especially the non-rebreather mask. Make sure that you recognize this well, because there could be that other, the partial rebreather, which doesn't work as good as the non-rebreather. So we want to make sure that we recognize this one properly. The characteristic of this mask, actually, it can provide an FiO2 of about 100%, like 0.9 to, or like a, 90 to about 100% with a fresh O2. Okay, so again, this is the best way of delivering the oxygen for the patient with a severely low oxygen level. Now, you got to be careful though with the non-rebreather mask. As soon as the patient will have some improvement with their breathing, then you still need to keep monitoring their oxygen levels, their saturation through the pulse ox, or it could be with the use of the ABGs. Make sure that you have that information in order that we can follow through with the oxygen therapy. How are we going to do this one? Well, definitely if there is some improvement, probably we're going to have to change the delivery method, maybe have to go down with the concentration, because with the prolonged use of the non-rebreather mask, this can also cause carbon dioxide buildup and can also lead to suffocation. So we really don't want to keep this patient using the same non-rebreather mask all throughout, okay? If they're not gonna have some relief from the non-rebreather mask, of course, you need to make sure that the next appropriate intervention is provided to them, maybe with the use of the non-invasive ventilation, which is the BiPAP. And if they're still not responding to that, then definitely make sure that you are notifying the healthcare team, the medical provider. The patient probably would need the intubation and mechanical ventilation. All right. So let's go through the other options here. Letter A, simple mask. Well, we remember that the simple mask, the simple mask is very, the lowest delivery system here. It can only deliver about 24 to 44%, okay? 24 to 44%. And this will not be sufficient for this patient with a severe pulmonary edema. And you cannot really deliver more than 1 to 6 liters via nasal cannula. You can't. You just can't. And remember about the nasal cannula, as soon as you're going to deliver it, let's say 4 liters per minute, it can dry the nostrils. And so you got to make sure that you have the humidification system attached to the oxygen setup as well. But again, this is not sufficient for this patient. I'm talking about the nasal cannula. Sorry. The simple mask, rather, I should say. I got the wrong arrow right there. For the simple mask, it is not going to deliver the same amount of oxygen. It can only give about 40% of FiO2. And again, this is not going to be sufficient for the patient as well. All right. So about 40 to 60% of FiO2 on this simple mask. Okay. All right. I got distracted here. Again, the nasal cannula can give about 24 to 44% FiO2 with a delivery rate of 1 to 6 liters per minute nasal cannula, whereas your simple mask can deliver FiO2 40 to 60%, okay, or concentration rather. Now, we have the last one, which is the face stent. Have you seen this one, guys, in your clinicals? Well, the face stent is not really advantageous for this patient because it will provide a variable oxygen concentration. And so it's not going to be a reliable treatment method. It can give about 30% to 50% O2, okay? And this is only intended for these patients that cannot tolerate the mask that will fit tightly to their faces, and also intended for those patients that may have facial trauma, or for those patients that may have claustrophobia. But again, this is not really applicable for this patient with a pulmonary edema. Okay, facial trauma and claustrophobia. Claustrophobia. Got it. All right. Now again, our test taking scale here would definitely need to make sure that you recall the different delivery methods, the amount of oxygen that they can deliver, and the appropriateness on their usage. All right. So make sure that you're also identifying the manifestations that are given in the scenario. So what we have here, we have dyspnea, and also what do you call this? This is orthopnea, right? They will not be able to really get a breath when they are 45 degrees angle, so they need to sit upright or maybe leaning forward. And so this is much severe form of dyspnea here. And of course, a saturation of 85%. That is very low, okay? Now, also, guys, remember about the delivery methods. Make sure that you are appropriately providing them the correct delivery system in order that we can correct the hypoxemia. Okay. Now, we're going to have to go to the next question here. All right, good thing that you can still see this. It says at 10 a.m., a male patient arrives at the emergency department with a respiratory rate of 40 breaths per minute, showing signs of anxiety and audible wheezing. He is immediately given oxygen through a partial rebreather mask and an intravenous dose of methylprednisolone. By 10:30 a.m., his arterial blood oxygen saturation is 84 and wheezing persists. What should the nurse administer next? Okay, back to the scenario. At 10 a.m., the patient arrives at the emergency department with a respiratory rate of 40 breaths per minute, showing signs of anxiety and audible wheezing. He is immediately given oxygen through a partial rebreather mask and an intravenous dose of methylprednisolone. By 10:30 a.m., his arterial blood oxygen saturation is 84%, and wheezing persists, what should the nurse administer next? Is it A, salbutamol? Is it B, propranolol? C, midazolam? And D, morphine sulfate. We just got this short as morphine. So what would be your answer here, guys? I see a lot of you are answering letter A. Okay, let's find out. Well, the correct answer here is letter A. That is for sure 100% correct. Well, before we go through the rationale, let's go back into the scenario here, because this is really important for you to make sure that you have captured the entirety of the situation and also the patient's overall features. You don't want to miss any of the manifestations here. So our patient is tachypnic at 40 breaths per minute. That is very significant. Your patient is hyperventilating, tachypnea. And there's also signs of anxiety and audible wheezing. You don't even need a stethoscope around this time. You can hear it. We don't know if it's both expiratory or inspiratory, but you can hear the wheezing. That musical sound just is, no, I don't like to hear the wheezing sound at all. That simply means that the airway is narrowed. We don't want that. There is a compromise in the airway. Okay? This is a priority issue. Airway problem. Wheezing? Bronchi? I don't like those. That simply means that I have to be on my toes and immediately would have to intervene. Okay? So, he is immediately given oxygen. So that was one of the preliminary interventions, given oxygen through a partial rebreather mask and an intravenous dose of methylprednisolone, which is basically a glucocorticoid, and it has a rapid onset, of course. But at 10:30 a.m., the arterial blood oxygen saturation is 84%, and the wheezing is still there. Okay. I don't know what happened, why we don't have any other information other than the methylprednisolone that was given before 10:30 and oxygen, nothing else. We have limited information. And so just selecting into the options here, salbutamol, propranolol, midazolam, morphine. Do you think that morphine can open the airway? Of course not. Eliminate that. This is a medication that can cause central nervous system depression. And it can also cause respiratory depression. So you're going to eliminate this one right away. And why would you give the morphine this time? There's no indication, right? Maybe? No, I don't think there's really an indication around this time. There's no complaint of any pain or any kind of like a chest pain. No, not at all. What about letter C, midazolam? This is a sedative medication. And of course, is there a need for us to give midazolam for this patient that has a respiratory rate of 40? Maybe you will get fooled into answering the midazolam to calm down the patient, but it's not appropriate. This can also cause central nervous system depression, and it can also suppress the respiratory function. We don't want that. And of course, noting into the saturation of the patient that is already 84, we don't want to cause more hypoxemia. No, eliminate letter C right away. So these are your distractors. What about letter B? Do we see anyone answering letter B? I don't think so. Good. So letter B is a beta blocker. And this is specifically a beta blocker that is non-selective. Okay? So this is a beta blocker that is non-selective. So this can block both the beta receptors in the lungs, and also it can block the beta receptors in the hard as well. Okay, so this can lead into the constriction of the airway. So we don't want any type of beta blockers for this patient with the issue with airway problem. We don't want to cause more issue with that bronchospasm, the wheezing. So we don't want any propranolol, okay? Right? So again, we have only one answer, which is the salbutamol, which is characterized, or it is classified as the beta adrenergic agonist. This is the only medication that can benefit, or that can be beneficial to the patient. Beta 2 adrenergic agonist. Okay. So the effect here is to cause dilation of the airway. It's going to relax the smooth muscles in the lungs. Okay. Again, the propranolol is contraindicated. We don't want any of the beta blockers touching our patient. We want bronchodilation, not bronchoconstriction. Okay. So that's it. So what is your strategy in order for you to answer this question safely? Well, of course, you have to review the pharmacologic effect or the therapeutic effect of each medication. For example, if with a propranolol, definitely eliminate that one. Olol, if you see any of those beta blockers with a olol, do not administer those. Even though in some textbooks it will say that the cardioselective will be safer for those patients with COPD or asthma. However, they can still cause some bronchospasm and bronchoconstriction if the dose gets higher. So that's the caveat right there. Even though they're considered cardioselective, we still need to be cautious in administering the selective or cardioselective beta blockers, because this can still cause the bronchospasm or bronchoconstriction in a patient with a history of asthma. Okay, so always be cautious, guys. Now let's move forward with the next question. In a COPD patient administered supplemental oxygen through a non-rebreather mask, which parameter in the arterial blood gas analysis best reflects the efficacy of oxygen therapy? Again, in a COPD patient administered supplemental oxygen through a non-rebreather mask, which parameter in the arterial blood gas analysis best reflects the efficacy of the oxygen therapy? Is it A, pH, B, partial pressure of arterial oxygen, or is it C, bicarbonate, or D, partial pressure of arterial carbon dioxide? Yeah, I'll get back to you, Robinson. Okay. What's your answer? Obey answered C. Mary answered D. So again, the question here is in a patient about an issue with a COPD diagnosis, and a supplemental oxygen has already been given to the patient through a non-rebreather. Oh boy, non-rebreather mask. Oh, okay. The irony. COPD patient administered supplemental oxygen through a non-rebreather mask. Which parameter in the arterial blood gas analysis best reflects the efficacy of the oxygenation therapy? Your answers are pretty much close to letter D. Every one of you answered D. Few answered C. Okay. Well, the correct answer here is letter, drum roll please. The correct answer here is letter B. And why is letter B the correct answer? We are going to have to look for the partial pressure of the oxygen, not the carbon dioxide. Okay? The reason for that, it's because the partial pressure of the O2 will give us a better measurement. It will give us a better picture of how well the oxygen is being delivered to the blood. Okay. So I'm wondering here, guys, that this patient probably is getting the non-rebreather mask as a rescue delivery or oxygen delivery method, but not really in a prolonged state, because this patients are really going to drown in CO2. So again, the letter B is the correct answer because it can give us the better picture of how well the oxygen has been delivered to their bloodstream, right? And definitely our goal for this patient is to increase their partial pressure of the oxygen in order that they're gonna get oxygenation. We don't really want 100% here, guys. At least we'll reach maybe about 89% to 92%. We don't really want to expect 95% oxygen saturation or 100. No, that's just unrealistic. We don't want that because the oxygen itself can become toxic to this patient. All right, so please take note of that. That's why I was kind of like, non-rebreather mask. But again, this is like a real, probably a setting that the patient is given the non-rebreather mask. So that's kind of like ironic. All right, so what about letter D? Why is it incorrect? Well, the letter D, which actually partial pressure of the arterial carbon dioxide, this is going to give us the exact level of the CO2, right, in their bloodstream. But again, this is not the primary measure for evaluating the effectiveness of oxygen therapy, okay? The person with COPD basically have higher levels of the CO2 in their bloodstream, but not really acidotic, but most of the time they're going to be leaning towards high CO2. And of course, it doesn't really directly indicate how well the oxygen therapy is being effective in improving their hypoxemia. And so this is going to be a secondary source of information. So I would select this as the second source of information after selecting letter A. All right. So that would be how I'm going to be picking the answer. If I have the opportunity to answer like according to the category, I would do that. But definitely for this scenario, we're only going to select one best answer, and that is letter B. Now, why letter A is wrong? Well, it's obvious, right? It's incorrect. When the pH is going to be considered here, it's not going to give us a direct link of how the effective the oxygenation has become to our patient. And so the pH can only be affected by so many factors, maybe increasing or let's say metabolic acidosis, retention of the hydrogen ions, but it's not really specific to the oxygen delivery. So we are getting rid of the pH. For letter C, bicarbonate. The bicarbonate really is going to be useful when we are looking into the metabolic imbalances, okay? Especially if there is a problem with the excretion of the hydrogen ions. Let's say, for example, maybe the patient has a renal disorder, chronic kidney disease, or acute renal failure. They might end up with a metabolic acidosis. But at this point, the bicarbonate will not really reflect how well the oxygen therapy is effective for this patient, okay? Now, for the testing strategy, I just want to emphasize here, guys, that you need to really recognize what the question is asking, okay? And it's asking for the efficacy of the oxygen therapy. So definitely you need to look for that parameter that will measure the oxygen levels, which is letter B, okay? So that's your best answer, okay? Now, we're going to proceed with the next question at this point. Oh, before I go to the next question, Robinson asked earlier, anxiety has tachycardia and salbutamol can cause tachycardia. Yes, guys, the beta-2 adrenergic agonist can also increase the heart rate of the patient. That is why you have to really educate them about the proper use of the albuterol when they're using the albuterol at home, let's say the MDI, or let's say the nebulization at home. You really have to teach them about the strict compliance on the intervals, on how they should be delivering their medication. Let's say, for example, if the order is every 4 hours or every 6 hours, they need to stick to that intervals, because if they're going to take the medication as frequent as they desire, we know that the medication can already stimulate the heart to cause tachycardia, right? It's already known to cause that side effect. It will cause tachycardia plus the anxiety. And so if they're going to be using the medication much more frequently, well, expect that they're going to end up with arrhythmias, right? We don't want that. And again, this patient needs to be to have proper re-education on the use of the albuterol in order for them to prevent getting the side effects or the complication of the albuterol therapy. Okay. All right. Let's move on to the next question. All right. If a patient on a ventilator continues to hypoventilate due to respiratory muscle weakness, the nurse will continually assess for a complication of A, metabolic acidosis, B, respiratory alkalosis, or C, respiratory acidosis, and D, metabolic alkalosis. The situation says, if a patient on a ventilator continues to hypoventilate due to respiratory muscle weakness, the nurse will continually assess for a complication of A, metabolic acidosis, B, respiratory alkalosis, or C, respiratory acidosis, and D, metabolic alkalosis. Looks like you have picked B. Most of you guys have answered letter B, which is respiratory alkalosis. All right, are you sure about the letter B? Guys, our situation here, it's stated that the patient continues to hypoventilate, meaning the rate of the respiration is slow. Okay? Remember about the exhalation and the inhalation process, and also the what do you call this? How the body will be able to expel the CO2 if there is hypoventilation, right? Okay, I just want to make sure that you understand the question. The patient is hypoventilating because of the muscle weakness. And of course, we are going to look for the complication about the hypoventilation. So good thing I'm seeing letter C right now. Respiratory acidosis. That is the correct answer. Well, why? Well, because when the patient is hypoventilating, even on a ventilator, this can really allow the CO2 to accumulate, okay? Letter C, respiratory acidosis. There will be retention of the CO2 in the bloodstream because it's not able to get rid of the carbon dioxide. Right. Thank you, virtuous lady. Right. Acidosis is going to occur, respiratory acidosis to be specific. This is something that will occur fast if the patient is not breathing out the CO2. Okay, if there is accumulation, if the ventilation, the rate of the respiration is slower, I'll just say it like that. If the respiration is lower, there will be a decreased the rate in expelling the CO2 will be decreased. CO2 removal. I'll just simplify that. If there is decreased respiratory rate, this will also decrease the CO2 removal in the bloodstream. That's why there is acidosis. If there is increasing respiratory rate, such as when the patient is hyperventilating, then the person will end up with rapid CO2 removal. Okay, so this is going to be related to alkalosis. This one and this one relates to that. Okay, I hope that you're able to get this one. Okay, let me say that again. When there is respiratory acidosis, this will cause, or if there is low respiratory rate or hypoventilation, this will lead to accumulation of a CO2 in the bloodstream. Whereas if the patient is hyperventilating, rapid removal of a CO2 will occur, and this is much more related to respiratory alkalosis. All right. Now, how about metabolic acidosis? It's not really related to the issue because we are not talking about the kidney impairment. We are talking about a respiratory problem. And so we are going to eliminate this one right away. So this is only going to occur if the patient probably has some issue, let's say diabetic ketoacidosis. That is one. Or when the patient has severe diarrhea. Okay, that is for metabolic acidosis. What about metabolic alkalosis? What is that? Well, this problem can arise when the patient probably has some prolonged vomiting, when they are losing way too much hydrochloric acid. Or, for example, maybe the patient is having that continuous, I would probably not say continuous, but prolonged nasogastric, I cannot really read what I'm writing, nasogastric tube. If there is decompression of the stomach, this will cause rapid loss of the hydrochloric acid. All right, so this can lead into metabolic alkalosis. And also you have your prolonged vomiting. So please don't forget these very simple association, guys. Don't forget, if you are vomiting way too much, you're losing hydrochloric acid. So that is alkalosis, metabolic alkalosis. If you are losing way too much of the alkaline through the rectum, in a case of diarrhea, because our intestinal fluids are actually it's alkaline in nature. It's basic. And so if you're losing way too much of the intestinal fluids, then the person will end up with the metabolic acidosis. Okay, so just simply as that. Don't make it so complicated. All right. Now we're going to tackle here the test taking scale. What do we need to do with this test item? Well, again, we are going to have to focus on the problem. Yeah, ABG. That's very important, guys. We're going to do a whole lot more of the ABG in the next sessions. This is just the preliminary. And so I'm going to look for some more difficult questions for you. Again, the test taking skill here is to make sure that we are identifying the problem, which is the hypoventilation because of the muscle weakness. So again, with that, this will lead to CO2 retention. And I really want you to go back into the simple pathophysiology and hope that you are able to differentiate between the metabolic and the respiratory conditions. But again, our focus here is on the respiratory side. The more that the patient's respiration is lower, think about CO2 retention. Okay, that's it. We don't want to complicate the thing here. So that's your strategy. Let's move on to the next question. Following a thoracentesis, which clinical manifestations suggest a complication requiring immediate notification of the physician? Following a thoracentesis, Which clinical manifestations suggest a complication requiring immediate notification of the physician? Is it A, low blood pressure and hypothermia, or B, tachycardia and pallor, C, hyperthermia and hypertension, and D, serosanguinous drainage from the puncture site? Okay. The question states that following a thoracentesis, which clinical manifestations suggest a complication requiring immediate notification? A, low blood pressure and hypothermia. B, tachycardia and pallor. C, hyperthermia and hypertension. D, serosanguinous drainage from the puncture site. Now, go back to the situation, guys. Following a thoracentesis, which clinical manifestation suggests a complication requiring immediate notification of the physician? So I want you to think about the manifestation that can potentially occur as soon as possible when the procedure is done. Okay, so this could probably comprise about those immediate complications. All right, this is a little bit tricky, but I want you to really recall the fundamental concepts about the hemodynamics, which would be the earliest sign that you can see in this patient. Okay, I've seen B's and A. All right. Let's go through the selections here. Letter A, low blood pressure and hypothermia. What is that? Is that going to be the earliest manifestation right after a thoracentesis? Possibly. Okay. It might indicate some bleeding, but take a look into the corresponding hypothermia. Do you think that hypothermia can set in as soon as the blood pressure goes down? No. Hypothermia can happen mostly at the later stage, especially at the later stage of shock. Hypothermia is not really evident around this time. That is why this makes this option incorrect. Okay. Low blood pressure is, I would say, probably second to the priority answer here. It's not really the topmost sign that there is a bleeding. Okay. What about letter B? Tachycardia and pallor. Guys, I really want you to observe this one. I really want to draw your attention here because going back into the concept of shock, hypovolemia, bleeding, tachycardia is the earliest sign of blood loss. Please don't forget this, okay? Tachycardia and pallor. Well, the explanation for that, it's because the tachycardia is a compensation. It's actually going to be generated as soon as the baroreceptors in the body detect the changes in the blood volume, right? So it will now elevate slightly. The tachycardia may not be so high, but it will go up. This is very fundamental, guys. I really want you to retain this concept that tachycardia is the earliest sign of blood loss, along with tachypnea, an elevation of the respiratory rate. Okay, now the tachycardia is basically a compensation. There is a drop in the oxygen level, or let's say a blood loss. So let me just put it right here. Earliest sign of low O2, not just hemorrhage, but low O2, and also blood loss. Okay, so we're just not talking about bleeding here. We're also talking about the oxygenation. So again, tachycardia is the tachycardia is the indicator that there is a considerable amount of blood loss, and also there is a drop in the oxygenation process. And of course, the pallor, which is going to be closely associated with that because of the decreasing blood flow to the skin. That is why it's not disqualifying the tachycardia. So both are early signs of blood loss and decreased tissue perfusion. Do not forget this. This is in fundamentals of nursing, guys. Tachycardia and pallor. Okay. Low blood pressure would follow next. Okay. Don't forget that. If you answered letter C, hyperthermia doesn't usually occur right after a thoracentesis. Okay. Hyperthermia is an indication that there could be an infection going on, but this doesn't happen immediately after the thoracentesis. It will take maybe a good 24 hours, maybe 48 hours, and this is a sign that the patient is getting an infection. Maybe there is a sterile technique during the insertion of the needle. This can really cause that infection. And if you answered the letter C, hypertension is not really going to give us an indication that the patient has hypoxemia or blood loss. Most often, our patient will be having low blood pressure. Now, letter D, serosanguinous drainage from the puncture site. This is another indication that there is an infection. All right. And this is going to, or serosanguinous really is something that would call for a frequent monitoring. Rather, it is not an immediate life-threatening complication to the thoracentesis. Okay, so the serosanguinous is only a sign that there is that, okay, it's a drainage. You need to keep watching that one. You need to take a look into the band-aid. If there is more shadowing, if there will be more, then that would really be concerning. But if there is not a significant amount of drainage coming out from the site, then it's the least of our worries here, guys. Okay. And so we want to make sure that we are going to keep an eye on this one. Make sure that you are telling the next shift RN, hey, this is what I've noticed. I'll show you the shadowing of this band-aid. This is the size. I mark this is the boundary or the border of this drainage. So make sure that the next shift nurse will be able to see the baseline information in order for them to keep an eye on that drainage as well. But again, at this point, this is not alarming at this stage. So go back into the concept of hemodynamics or low oxygenation. Tachycardia and pallor are the earliest signs, okay, for the blood loss and hypoxemia. All right. So again, the option B is really going to give us an idea, especially if there is an early deviation from the normal. So tachycardia probably would start as maybe 88 beats per minute, and the previous heart rate was probably 75, 78. And then maybe in the next 30, 45 minutes, an hour later on, there is an increment in the heart rate. Even though it's less than 100, but if there is an increment in the heart rate, that is already a good sign that, or a bad sign, I should say, that the patient is starting to creep up with that compensation. There is now a decreased oxygenation to the body, or let's say there is an ongoing blood loss inside. So you need to keep an eye onto the heart rate. It's not because that it's less than 100 that it's still acceptable. Hey, I'm not going to worry about that. No, that's really wrong. You need to keep an eye on the trend of the heart rate, okay? And also the respiration, because they are closely linked to each other, okay? So for example, if the respiration rate was previously maybe in the 22 cycles per minute, and then maybe an hour later on it went up to 24, that is already significant, guys. Or 25, 26, that is already significant. So you really need to keep an eye out on this patient. They are probably losing some blood inside, or there is some compression into the lung. Guys, the thoracentesis itself is already dangerous. Okay, so for example, if the thoracentesis was done to get rid of the excess pleural fluid, probably it's draining the fluid, right? But however, if there is an accidental puncture into the lung, then it can lead into the pneumothorax, right? And so if there is now an incidence of pneumothorax, this is going to compress the affected lung, okay? So it will not be able to expand when you are breathing in, right? So when that happens, this will now compress also the vena cava itself, okay? So let me just draw that lung right here, right? So supposing this is the affected site, and this is the heart, and we have the vena cava over here. If there is pneumothorax, now the presence of air in the pleura because probably of a accidental or inadvertent puncture up to the pleura. So this is going to compress the vena cava and also the heart. So this is going to decrease the venous return. So meaning there will be decreased preload, and also the patient's cardiac output will also be decreased. So there is going to be much more complication to occur in this scenario if there is that pneumothorax that can occur as a complication to the thoracentesis. Internal bleeding will elevate the heart rate. Yes, of course, it can. So if in a case of either pneumothorax, or it could be that there is bleeding, puncture into the lung itself, it's now converted into the hemothorax. So there is now rapid accumulation of blood in the pleural space. And by gravity, the blood will accumulate into the lower section of the lung, right? So the same thing, it will also compress the vena cava, the preload will drop, and of course the body will sense that, hey, something is not right here. I'm not getting enough oxygen. And so the body will tend to cause the heart to beat rapidly. So the patient will be more tachycardic around this time to compensate for the low oxygenation and also the blood loss. All right. So I hope that you're able to capture all those important concepts, especially with a complication, as a complication to the thoracentesis. All right. Now let's get moving here with the next question. A nurse is administering metoprolol. Good thing I was able to pronounce that. It's a tongue twister. A nurse is administering metoprolol through a metered dose inhaler to a patient following a prescription of 2 puffs every 4 hours. Oops, hang on. Let me adjust. So let me just move the text a little bit downward so you can see it. Okay. All right. Let me just do some more on the other slides as well. Okay, hang tight. Okay. Give me a few more seconds here. All right, and the last one. So let's go back to that question. A nurse is administering metoprolol inhaler through a meter dose inhaler to a patient following a prescription of 2 puffs every 4 hours. The nurse emphasizes the importance of promptly reporting any potential side effects. What adverse reactions related to metoprolol should the nurse instruct the patient to watch for? Okay, the question is, a nurse is administering metoprolol through a meter dose inhaler to a patient following a prescription of 2 puffs every 4 hours. The nurse emphasizes the importance of promptly reporting any potential side effects. What adverse reactions related to metoprolol should the nurse instruct the patient to watch for? Is it A, peripheral edema, B, arrhythmias, C, bradycardia, D, constipation? I'm seeing Maria Elena answering B, Ube answering C, Robinson answering B, Chica B, Stacy A, Mary B. Let's find out, guys. Now, don't forget about the classification of the drug. All right, don't forget that. Don't forget metoprolol. What is that? What drug class does medication belong to? Okay. So again, what adverse reaction related to metoprolol should the nurse instruct the patient to watch for? Is it A, peripheral edema? Does the medication cause peripheral edema? That is actually incorrect, guys. It is not a common side effect of metoprolol. However, the peripheral edema is often associated with heart failure, okay? But not really a side effect to the metoprolol, okay? So again, this is a common manifestation of congestive heart failure, especially the right-sided. Let me be specific. Let me erase that. The right-sided heart failure. Right-sided heart failure. So that is the condition that can cause peripheral edema. Now, if you're going to ask me what medication can cause peripheral edema, calcium channel blocker. Okay, please don't forget this. This is a very common occurrence. Calcium channel blocker. My brain is way too fast, but my hand can't keep up. Calcium channel blocker. Okay, and the reason for that, it's because the rate of the contraction of the myocardium, the ventricle, is kind of slowed down. It has a negative inotropic effect, and so the fluids will tend to accumulate in the dependent areas, especially the ankles. Okay, so let's find out about letter B, arrhythmias. Sounds like it's a correct answer. Well, remember about the drug class, about the metoprolol. This is a beta adrenergic agonist. Okay, so this is a bronchodilator. Beta 2 adrenergic agonist. Remember about its effect into the beta 1 receptors, right? It can also excite the receptors, especially in the heart. And that is why it can lead to increased heart rate, right? There will be tachycardia, okay? And this is, even though it's going to help with the breathing, it always has a side effect, and that is the tachycardia. The patient will feel like bounding pulsations in their chest. And again, you really need to emphasize teaching them the proper administration, especially with the intervals of getting that medication. All right. Again, that is the side effect: increased heart rate. Okay. Irregular heartbeat can be another side effect. Irregular heartbeat. Irregular HR. Another is palpitations. That bounding. Palpitations. So those are the side effects of the beta-2 adrenergic agonist. Again, palpitations, tachycardia, and irregular heart rate. So once you're going to assess the irregular heart rate, which is probably going to be a new occurrence for this patient, this is a reportable issue, guys. Please do not sit on this, okay? If this is a new onset of an irregular heart rhythm, you gotta talk to the doctor, the medical provider. It could be the nurse practitioner, could be the physician's assistant, or it could be the doctor, the DO, or the MD. Make sure that you communicate any abnormal occurrences, any deviation from the normal that would be life-threatening. Yes, it warrants immediate notification, okay? And we want to make sure that this is addressed accordingly. What about letter C, bradycardia? Well, we already know the side effect of the beta-2 adrenergic agonist. So you eliminate the bradycardia because it doesn't do that, okay? It's an agonist. It will cause the dilation of the bronchus. It also will cause the rapid heart rate because it will stimulate those receptors that are found in the heart. Okay, so tachycardia is common. Bradycardia is no. Okay, constipation. Well, do you think constipation is something that could happen in a patient taking the metoprolol? No, it's unlikely. Guys, the GI manifestations are known to be rare. Okay, so let's just cross out the constipation here. There could be some GI manifestations or GI side effects, but they are known to be rare. And these are your nausea and vomiting and diarrhea. Okay, please don't forget these three things. NVD, nausea, vomiting, diarrhea. Please don't forget that. These are the side effects of the metoprolol, but they occur rarely. Just to give you that idea that they occur rarely. They can also develop some anorexia. As I've seen in the drug handbook, yeah, it's marked there that they rarely happen, but maybe the patient that you're taking care would be one of those rare. So good luck. Yeah, it can happen. But again, in the general population, it doesn't occur most often. All right. So again, our test taking strategy here is to recall the drug classification of the drug, of course, the medication, in order for you to recall the effects. Okay. So let me just clear this out because let me clear the whole thing here. So you will have a fresh set of information. So let me just write this carefully this time. Beta-2 adrenergic agonist. So again, it will target the beta-2 receptors and also the beta-1 receptors. So this is for the lungs. It can cause bronchodilation. That's why it's effective in treating any airway spasm. And here, the beta-1 can cause increase in the heart rate. But the side effects that we will be keeping an eye on, let me just rewrite that. Side effects. So what are those side effects that I said earlier? One of those is palpitations, right? Bounding pulse, palpitations. There's also irregular HR, okay? And the known tachycardia. And we are talking about tachycardia that could be greater than 140 beats per minute. Yeah, that's really rapid, guys. When the patient has tachycardia, they're going to end up with just way rapid heart rhythm, but they're not really going to deliver enough oxygenated blood to the system. The body organs will not be getting enough oxygen if the heart rate is way too fast. It's just pumping way too hard, but not delivering enough fuel to the body. And so chances also is that the patient might end up throwing a clot. So that can be another complication that could occur into this patient. As a complication to the beta adrenergic agonist. All right, let's move forward here with the next question. A 30-year-old male patient with a history of asthma is admitted to the emergency department. The nurse, almost they just sent side effects. Okay, let me get back to you, Obey. All right, so the situation here, it said, a 30-year-old male patient with a history of asthma is admitted to the emergency department. The nurse notes that the client is dyspneic with a respiratory rate of 33 breaths per minute with nasal flaring and use of accessory muscles. Auscultation of the lung fields reveals greatly diminished breath sounds. Based on these findings, what action should the nurse take to initiate care of the client? Let me reread the question. A 30-year-old male patient with a history of asthma is admitted to the emergency department. The nurse notes that the client is dyspneic with an RR, or respiratory rate, of 33 breaths per minute, nasal flaring, and use of accessory muscles. Auscultation of the lung fields reveals greatly diminished breath sounds. I like that. Greatly diminished. Another descriptor of a diminished breath sounds already. Well, what do you think? Based on these findings, what action should the nurse take to initiate care of the client? Is it A, administer albuterol, B, draw blood for an ABG analysis and send the client for a chest x-ray, C, encourage the client to relax and breathe slowly through her mouth, and D, initiate oxygen therapy and reassess the client in 10 minutes? I'm liking your answers. Looks like we have a straight A here. Okay. Any more? All right, looks like most of you guys are answering letter A, administer albuterol. Okay, let's go back to the scenario. Your patient has a history of asthma, admitted to the ED. Okay, of course, he is now dyspneic. Respiration's 33. Nasal flaring. Nasal flaring is a subtle sign, guys. It simply means that the body is not getting enough oxygen, and it's just one of those accessory structures that will just reveal, like, hey, this patient is running out of air. The accessory muscles, this could be with the use of the sternocleidomastoid muscles, or it could be the suprasternal, or it could be the intercostal muscles, right? Use of accessory muscles. So we're not really specific what muscles have been used for this patient. And now the auscultation revealing diminished breath sounds. Diminished breath sounds is not good. It simply means that there is no more exchange of gas, right? There's no more entry or exit of the air from the alveoli, right? You can't hear any movement of air. So it's like static. Could be a sign of lung collapse, atelectasis. So your answer is letter A. Yeah, that is the correct answer. You have the given scenario already with a patient's history of asthma. That is the correct answer. Albuterol will treat the bronchospasm. And this question is quite tricky. It did not even tell us that the patient has wheezing, right? No, it did not say that. It only said about diminished breath sounds. Yeah. So our intervention here is to administer albuterol. For what reason? Well, did we have any? Okay. Dyspneic, respiratory rate of 33, accessory muscles, greatly diminished breath sounds. Okay. So our patient here could possibly have an issue with the narrowing of the airway, even though we don't have that wheezing sound in the scenario. Our priority here is to make sure we maintain patent airway. Okay. Maintain patent airway. Given that we have a patient that has a history of asthma. Okay. So again, our goal of therapy here is to make sure that we are opening up the airways. We want to make sure that it's opening up again in order to allow the exchange of gases, the passing of the CO2 and the O2 in the airways. It could be the major or the minor airways, or the smaller or the bigger airways, right? And so that is going to be relieved by the use of an albuterol, which is a short-acting adrenergic short-acting beta adrenergic agonist. So that is the SABA, which is a rapid-acting bronchodilator. We really want to re-establish the patent airway to improve their oxygenation and also to lessen their effort in their breathing. So these are like signs of overexertion. The body is really trying to maintain the amount of air, but they just can't. It's just trying to compensate by the use of these accessory muscles. Okay, they're ineffective. Okay, and we really want to make sure that our patient is stabilized around this time. We don't want this patient to deteriorate, because once they get so tired in their breathing from being tachypnic, and if there is no intervention given, this patient can go downhill. They can be bradypneic later on. They will get exhausted, and then your patient ends up with the metabolic acidosis. So we want to make sure that we are addressing this really fast. Okay. If you had answered letter B, which is really good, I don't see anyone answering letter B. Draw blood for ABG analysis and send the client for a chest x-ray. Yeah, that can be done later once we reestablish or once we treat the patient's difficulty of breathing. Let's say, letter C, encourage the client to relax and breathe slowly through the mouth. Well, letter C seems too good to be true, right? This is something that you can do once the patient has been stabilized. Okay, we definitely need to intervene this patient's problem by administering the appropriate medication. Okay, so letter C, it can only be beneficial for the anxiety management, but it's not going to be sufficient during the acute stage. No, it will not be effective around this time. So don't even bother answering letter C this time. If you answered letter D, initiate oxygen therapy and reassess the client in 10 minutes. This can follow, or this is not as a high priority compared to the administration of albuterol, because even if you're going to give a higher level of O2, but if the airways are not opened, it cannot go in, right? No, it will not. And so you want to make sure that you're going to open up the airways first before delivering the additional oxygen to the patient. All right. So our test taking strategy here, you want to make sure that you are paying attention with the ABCs. Guys, in cases like asthma, COPD, emphysema, acute bronchitis, always pay attention to the airway, breathing, circulation. This is very easy, okay? You don't have to complicate things here, okay? So when we are talking about the airway, what do you think would comprise in the assessment of the airway? You're going to have to pay attention to the breath sounds. Are they wheezing? Are they having difficulty of breathing? Is their respiratory rate elevated? Okay. The breathing, the breath sounds, are they wheezy? Do they have rhonchi? Do they have coarse crackles? Because mucus can also block the airway, right? And if you're listening to, let's say, wheezy sound, inspiratory or expiratory wheezing, then this is definitely going to be something that you need to act on immediately, because this is now close to probably a total closure of the airway if we are not treating the patient's asthma. Okay, and now if we are going to go to the B, which is pretty much like airway, breathing, circulation. Actually, I'm referring here at airway, breath sounds, the quality of their breathing. This is what I'm referring to. Let me rewrite that, because you will get confused with that just breathing word right there. So airway, that includes the breath sounds and also the chest wall movement. This is what I was pertaining to. Chest wall movement. The rise and fall of their chest and the respiratory rate. Okay, that's about the airway. Now, talking about the breathing, we're going to talk about some more on the quality and also the use of the accessory muscles here. Nasal flaring would be one. And then finally with letter C, looking into the O2 saturation. ABGs, I should say. Saturation and the arterial blood gas. Okay. Before we go to that section, hang on a sec. Let me just go back into my PowerPoint so I can show you that lecture. Wait a second, wait a second. Almost there. Okay. Airways, circulation, asthma. Where's that? Almost there. Okay, here we go. Let me present this slide one more time. Okay, here we go. Especially in the acute attack. Assessment of the airway, rather here we have the airway, making sure that you're maintaining the patency, and the B, rather, it's the breathing right there, is the respiratory rate, the symmetry, the effort, and the use of the accessory muscles. So this is why I am looking for this page, because this is my assignment of these manifestations and also those things that you need to watch for. For the A, you want to make sure that you're listening for the breathing, okay? Are they wheezy? Are they having some hoarse crackles? For the B, you want to make sure that you're looking into the quality of their breathing, the respiratory rate, the use of the accessory muscles, and also in the breath sounds in the lung fields when you're auscultating, okay? Now for the C, you have to take a look into their oxygen saturation, the arterial blood gas, and the level of consciousness, because the way the mentation of the patient, the alertness of the patient will give you an idea if the brain is still getting enough oxygen. The way they're going to respond to you, do they still are they still able to answer appropriately to the questions that you're asking? Are they oriented? Are they disoriented? And take a look into the skin color as well. Okay, so if there is now ashening, or let's say bluish discoloration around their mouth, or there is now mottling in their lower extremities, cyanosis, and if the cap refill is more delayed, then that is going to tell you that there is a compromise in the circulation. I'm talking about the blood supply, the oxygenation to the periphery. Okay, so please pay attention to the ABCs. All right, going back into that test item. So where are we at? Is that the one? Yeah, I think so. All right, SABA. Now, letter D, initiate oxygen reassess. Okay, so letter D. Why is letter D not the answer around this time? Initiate oxygen therapy. I think I've said already about the letter D. We're going to make sure that we have administered first the bronchodilator in order to allow the oxygen to enter into the terminal bronchioles and also to the alveoli. Okay, now I remember. Now let's go to the next question here. It said, a client needs an arterial blood gas drawn, and the nurse must perform an Allen's test before collecting the sample. Which action should the nurse take during the test? A client needs an arterial blood gas drawn, and the nurse must perform an Allen's test before collecting the sample. Which action should the nurse take during the test? Is it A, occlude the brachial and radial arteries, then release them and observe the hand circulation? Or is it B, compress the radial and ulnar arteries, release one, and assess the hand's color, and repeat the process with the other artery? Or C, apply pressure to the radial artery and monitor for color changes in the affected hand. And lastly, option D, apply pressure to the ulnar artery and observe for color changes in the affected hand. What is your answer here, guys? This is all about ABG procedure. Babay answered letter C. Apply pressure to the radial artery and monitor for color changes in the affected hand. Okay, please don't forget the fundamentals in those type of skills. Okay, make sure that you're doing this procedure correctly. Okay, so I'm just going to give you an overview. In the ICU setting, the critical care nurse can do their ABGs, drawing the blood from the artery. And so with the respiratory therapist, they are also the primary person to do the drawing of the arterial blood gas. We are seeing letter C, B, C, C, C. Okay. Apply pressure to the radial artery and monitor for color changes in the affected hand. Guys, please don't forget about the arteries that you need to check. Arteries, not just one. Okay? You want to make sure that you are checking the integrity first of the injection site before you're going to collect the blood sample. Okay? Make sure that you are checking the integrity about the collateral circulation in the arteries. Okay, so not just one. We are not talking about just one artery here. Okay, so with the Allen's test, the procedure will actually involve, the correct answer here is letter B. That is, compress the radial and ulnar arteries, release one, assess the hand's color, and repeat the process with the other artery. This is the correct procedure in doing the Allen's test, not just occluding the radial artery. Okay, please don't forget this. This is a commonly asked question, especially in checking the arterial or obtaining the arterial blood sample. Okay, so if you had answered only letter A, then that is quite limited. If you're occluding, hey, take a look here in the scenario A. Occlude the brachial and radial arteries. No, we don't use the brachial, so this makes it wrong. Okay, so eliminate that one right away. That is a huge distractor. We don't use the brachial artery for that. Okay, this is going to use the radial and ulnar arteries because these are the primary arteries supplying blood to the hand. Again, the radial and ulnar arteries. If you are occluding the brachial artery, then it doesn't really gonna give you a relevant information regarding the collateral circulation of the hand. If you had answered letter C, apply pressure to the radial artery only, then it doesn't really gonna test the collateral circulation. Okay, it doesn't really check for the artery's patency and the adequacy of the collateral circulation. So this is the reason why Allen's test is done. Whoops. Allen's test. So check for collateral circulation. And what arteries are we going to check? Well, of course, the radial and ulnar artery. All right. Radial and ulnar artery. So we will be able to see if there is some decreased blood flow, arterial blood flow to the hand. Okay, so if there is like diminished circulation, no, we're not gonna obtain the blood sample into that particular hand. No, we're not going to do that. Okay. So we want to make sure that both circulations or both sites, the radial or ulnar sites, are going to have adequate collateral circulation. Okay, so if you're only doing letter C or the radial artery, that's not going to check entirely the collateral circulation. And same thing with the ulnar. Yeah, it's pretty much the same as letter C. So our best answer here is letter B to adequately assess for the collateral circulation. Now again, our test taking skill here is to make sure you are going to refamiliarize the common procedure, which is testing for the collateral circulation when you are drawing the arterial blood gas. Okay, make sure that you do the steps exactly correctly. Okay, make sure that you are checking for that adequate blood flow to the hand. Okay. Now we are gonna move to the next question. A nurse is administering aminophylline or theophylline to a client with emphysema. What is the primary action of this medication? Is it A, suppress the cough, B, enhance expectoration, or C, prevent infection, and D, relax smooth muscles of the bronchial airway? All right, I'll wait for a few seconds here. We have a considerable amount of delay. So what is the primary action of this medication? This is a very objective type of question, but I would still study any kind of questions like this because this will really test your knowledge about the drug action, the therapeutic effect. You just can't ignore, guys. And we know that pharmacology, parenteral nutrition has a bigger percentage in the NCLEX. So make sure you don't neglect studying those drug action, therapeutic effects, side effects. There's so many of those. So we are answering letter D. Adiola answered D. Ube D. Virtuous Lady D. Dorje D. Shernette D. Shika D. Maria answered D. Yeah, that is the correct answer. Nothing else. To relax the smooth muscles of the bronchial airway. All right. So if you had answered letter A, it doesn't do the suppression of the cough. Suppression of the cough is antitussive cough medicine. Okay, that is the action of the antitussive cough medication. All right. Enhanced expectoration. This is the expectorant cough medicine. Prevent infection? No, we don't know anything about prevention of infection, or it doesn't do any of that stuff. So yeah. Eliminate letter C right away, ABC, and we're left with letter D. Quite easy to answer, but if I had revised this to a SATA, which I like to do, and I'll give some more SATA tomorrow and the next day. I'll make it more difficult for you guys. So you will be having some more mental exercises. Okay, so the answer here is letter D, bronchodilation. It will open up the airway, making the patient much easier in their breathing, okay? So the rest of those, those are just distractors. Now, what about this question? What treatments would a client with a primary pulmonary hypertension likely receive while being evaluated for a heart-lung transplant? Okay. Select all that apply. I'll make sure you'll get some more SATA tomorrow, because the SATA is actually quite similar to the matrix type of questions, the multiple select. So I'll give some more SATA tomorrow. Okay. I'll make sure you enjoy the session tomorrow. All right. So what treatments would a client with a primary pulmonary hypertension likely receive while being evaluated for a heart-lung transplant? Select all that apply. Is it A, oxygen, B, aminoglycosides, C, diuretics, D, vasodilators, E, antihistamines, and F, sulfonamides. All right, I can see that you're thinking, so I'll wait for your answers. Mary was fast. A, C, D. A, C, D. Okay, what about the others? What are the answers? Recall the concept that we discussed yesterday on the pulmonary hypertension. What about the rest of the guys here, or the ladies? What is your answer? Okay, I'll wait a little bit because we have a delay. There's that like 5 or 10 seconds delay from the live to the casting to your devices. So I'll wait. What are your answers aside from? Okay, we also have Chica answered ACD. Shernette answered ACF. Are you sure, Shernette? Are you sure about the F? Okay, don't waste your answers, guys. And we have Maria answered ABDF. ACD, we have ACD. Okay, guys, especially with the SATA, be careful that you are really narrowing your answers to the most correct answers, because in the next gen, if you're going to answer an extra wrong answer, this will be subtracted to the total points that you have gained. So you got to be careful, guys, with the SATA. You have to be careful. So make sure you narrow down your answers, okay, to the most correct. Make sure you do your answer by the elimination process, okay? So let's talk about letter A. Remember that the patient with the pulmonary hypertension, remember that they have hypoxia, right? Yes, they have hypoxia and hypoxemia. Hypoxia is the lack of oxygen into the bodily tissues, whereas the hypoxemia is, forgive my handwriting, guys. The hypoxemia is the lack of oxygen in the bloodstream. Yeah, quite similar, but in a sense, they're different. Hypoxemia. Yes, there is hypoxemia, hypoxia. It's because, remember about the pulmonary hypertension. So here's my heart looking like an avocado, right? So remember about the high pressure in the pulmonary circulation? That there is poor exchange. It's because of the narrowing in the blood vessels, the arterioles, the capillaries. And so it's gonna have to complicate into causing the blood to back up into the pulmonary artery, right? And the blood will go back into the right ventricle. Well, of course, this is going to happen not just overnight. It will happen for a long time. It is a chronic condition. And so the patient here has already the right-sided heart failure, okay? And with that, over time, the right ventricle will not be able to successfully or effectively push the blood from the right ventricle into the pulmonary circulation because of the weakened ventricles, right? So there is that hypoxemia. So we definitely include the oxygen therapy. Yeah, I'm seeing now more ACD. Very good, guys. You are correct. Why there is the delivery of diuretics? The reason for that, it's because of the right-sided heart failure. Remember about the heart failure that is congesting the blood into the right side of the heart, the atria, the ventricle. It will now congest the venous system, right? When it does that, you will see the JVD in the neck, and in the lower extremities, you will see the edema. Okay? And if it has progressed If it has advanced all the way more, remember about its effect in the liver, right? So there will be hepatomegaly. It can cause enlargement of the liver. There's also portal hypertension. And that is why the patient will end up with ascites, right? We don't want the ascites. This is just an extra collection of fluid in the abdomen, especially the peritoneal space. We don't want that. It will just cause compromise in the breathing because it will occupy space into the abdomen. So the diaphragm will not be able to expand downwards. The breathing will be affected because of that. The lungs will not be able to effectively expand as well because of the ascites. And so we want to get rid of the extra fluid from the abdomen. We want to get rid of the extra fluid in the extremities. We just don't want any of those extra fluid. We don't need them. There's no benefit of having the extra fluid. And so with that, we also want to decrease the fluid volume in the body, because the more that there is fluid accumulating in the bloodstream, it will also cause some more issues into the heart, right? The more it will work harder, it can probably lead into angina pectoris. There will be development of the chest pain. It's because angina pain. Let me just write that as angina pain. Because it's because it will cause some compromise into the perfusion of the coronary arteries as well. Over time, this will lead to that. And so they're going to end up with some chest pain and some more hypoxemia. So it will really overwhelm both the heart and the lungs. Okay, so that's why we need to give them the diuretics. Now you answered letter D, the vasodilators. Do you still remember the vasodilators that we talked about yesterday? Can you name those, please? So at least I'll know that you have learned something from yesterday. So what are those vasodilators? Do you still recall? What are those vasodilators that you remember? Remember about the phosphodiesterase inhibitor, okay? And this is represented by the sildenafil. Okay, this can cause relaxation of the muscles in the lungs. Okay, it will allow the passage of the blood for oxygenation, so it will benefit the patient. Now, do you recall those other vasodilators? Do you remember about the endothelin receptor antagonist? Do you remember that name? Or the prostacyclin? They do have different mechanisms, but they have the same therapeutic effect, which is to cause dilation of the pulmonary arteries and the arterioles. It will facilitate the passage of those blood for reoxygenation. Okay, very good for those who recall. And remember about the calcium channel blocker? Was it included? Calcium channel blocker, right? It can also cause the vasodilation. Okay, all righty. Now we are gonna eliminate those other options here, the aminoglycosides. We don't want the aminoglycosides. At this point, we don't have a information that the patient has an infection. Okay, if the patient has, let's say, a known infection that could be dealt with aminoglycosides, then yeah, we will include that. But if without that information, definitely we're not going to include any antibiotic treatment. No, there's no need. Antihistamines are not expected to be part of the therapy. Because the problem here is because of the hypertension in the pulmonary arteries, arterioles. the antihistamines are only indicated for any allergic reaction. We don't really need the antihistamines here. If there is some allergic reactions, go ahead, include that. But no, it's not needed at this point. Sulfonamides, this is a sulfa derivative, another antibiotic. This is indicated for those urinary tract infections, right? Sulfa drugs. So we don't need the sulfa around this time. So again, make sure that you go back into the drug classification, the therapeutic effects of the medications in order for you to really use this information when you are presented a complex scenario, okay? It could be in the form of, let's say, what is that type of testing? The bow tie? Yeah, you could probably be asked regarding what medication needs to be given in this patient. Could be a bow tie, what parameters to monitor, what intervention, what diagnosis. So yeah, there you go. Now let's move on forward to the next scenario here. It said a patient arrives at the emergency department with complaints of difficulty of breathing and chest pain, suspected of having a pulmonary embolism. What additional signs and symptoms would the nurse likely observe in this patient? Select all that apply. A patient arrives at the emergency department with complaints of difficulty breathing and chest pain, suspected of having a pulmonary embolism. What additional signs and symptoms would the nurse likely observe in this patient? Select all that apply. Yeah, Aldiola, you mentioned about the digoxin. Yes, this is going to be used as one of the pharmacologic therapy for the pulmonary hypertension, especially if there is already an involvement with the right side of the heart failure. Very good for recalling that medication. Yeah, very good. So Mary answered CEF, bradycardia, fast heartbeat, and blood-tinged sputum. Okay. Again, our scenario is talking about a patient with pulmonary embolism. Guys, if you have missed this session about the pulmonary embolism, I want you to go back to that discussion in order for you to get refreshed. I have talked a lot more about the pharmacologic management there as well, and also the different classifications, massive, submassive, and the mild form of PE. And so the different kinds of pathogenesis, okay? So what is your answer here? DEF. Okay. So what is your answer in this scenario? A patient arrives at the emergency department with complaints of difficulty of breathing, chest pain, suspected of having PE. What additional signs and symptoms would the nurse likely observe in this patient? Select all that apply. So most of you answered DEF, frothy sputum, fast heartbeat, and blood-tinged sputum. Okay, so let's break this down, guys. Okay, what is going on with letter A? Let's go through the following. Mild fever. Do you expect that the patient will be developing a mild fever in a pulmonary embolism? And I want you to think about the pathophysiology here. Remember about the lodging of that blood clot. It could lodge, the clot could be a big one. It could probably be a moderate size, or it could be a very tiny one. And remember about its effect regarding the different processes here. It's a foreign object that is lodging into that pulmonary artery. Okay, guys, please don't forget, the mild fever is actually one of those manifestations. Okay, and the reason for the mild fever, it's because it is occurring due to the inflammatory response, and it could probably be a result due to the tissue ischemia or caused by an infarction brought about by the embolus. So fever is actually one of the manifestations. So please don't forget that. What about letter B? Thick green phlegm or thick green sputum. Well, that is going to suggest a possible respiratory infection. All right. Let me just write this. INFXN, respiratory infection. This is less likely to occur in this patient, especially during the immediate phase. Because the situation stated here, a patient arrives at the ED, complains of difficulty of breathing and chest pain, suspected of having PE. So the thick green phlegm is not going to be expected during the acute phase around this time, okay? So this is more associated with the respiratory infection. It could be a bacterial pneumonia, okay? So we are going to eliminate letter B. What about letter C? Whoops. Bradycardia. What do you think about the bradycardia? Do you think this is going to be present in this scenario? Well, bradycardia is basically a heart rate of less than 60, right? In some cases could be less than 40, 30, okay? This is not a typical finding in PE. We are gonna eliminate that one. We are supposed to be seeing tachycardia. That is why letter E is going to be one of the answers here, okay? Fast heartbeat, okay? What about frothy sputum? Do you think frothy sputum is present in the PE? Guys, please take note. Frothy sputum is going to be associated with pulmonary edema, not PE, pulmonary embolism. So this is going to be associated with pulmonary edema, frothy sputum, okay? That is because of the shifting of the capillary fluid into the alveolar space because of the hydrostatic pressure that is increased in the pulmonary circulation. And that is why there is that crossing of the fluids into the alveolar. And because of the presence of air, this is going to make that frothy appearance, okay? So again, this is more associated with the pulmonary edema and congestive heart failure, okay? Congestive heart failure being the triggering or the starter or the aggravating factor to the pulmonary edema, all right? So frothy sputum is to be eliminated here. So we are left here with a fast heartbeat, which we already selected, right? And letter F, which is blood-tinged sputum. Guys, let me explain why blood-tinged sputum. Remember, this is also what we call as hemoptysis. Okay, we're not talking about TB, guys. We're talking about pulmonary embolism. Now, why is there a hemoptysis? Why is the person going to cough up blood-tinged sputum? Well, it is because there is that tissue infarction. The lung tissue, could be the alveoli or alveolus, will end up getting necrotic. It will die. It is because of the irritation caused by the embolus. When it's necrotic, it will not be able to function anymore. This will now be revealed as the coughing up of blood. That is the reason why they are having that blood-tinged sputum, okay? So don't forget about the hemoptysis. So we have the mild fever. We have, let me erase this entire thing. It's getting more confusing. Mild fever, the fast heartbeat, the blood-tinged sputum, okay? And the rest, you have to eliminate those. So guys, I really want you to recall the pathophysiology of the pulmonary embolism. So make sure that you go back to that video lecture that I have presented. Make sure that you understand how the clot lodges or forms in the pulmonary artery and how it can affect the body and how it can develop into those manifestations. But let me just go back into that slide instead. So we'll have a good refresher before we end our session today. Where are you? Pulmonary embolism. Getting closer. Okay, here we go. Remember about this slide. Okay. Remember about the lodging of that clot, okay, into the artery or the arteriole. So this is quite like a small clot. It's lodging into a small capillary. But the big deal here is when the patient is not getting the anticoagulation, this clot can grow bigger, right? If there is no heparin administration to that patient with a PE, if there is no heparin administration, then this clot can grow bigger. Probably the clot will now occlude this particular network of capillaries. That is quite dangerous, guys. Instead of being a small one, it will grow bigger if there is no anticoagulation. Now, if the clot is big enough to block a big chunk of pulmonary artery, then that is going to really cause that massive pulmonary embolism. Remember that? When the person will develop that massive pulmonary embolism, then it will cause right-sided heart failure because of the blockage, right? So for example, this is the clot right here, lodging into a big section of the pulmonary circulation. This will now cause backflow of the blood into the right ventricle. And within just a matter of hours, I'm not kidding, guys. That's why people with a massive PE, they can die right there and then once the clot lodges into the pulmonary artery because of the immediate right-sided heart failure. This is the scary part about this situation, wherein this can lead into a rapid right-sided heart failure. This will congest, it can weaken the right ventricle, and again, compromising the blood flow, the perfusion, and this will now also compromise the venous circulation. So there's so many things that can happen in a massive pulmonary embolism. There is that poor oxygenation. There's also right-sided heart failure. And of course, the ventilation will be affected. There will be a ventilation perfusion impairment, wherein the body or wherein the lungs can still breathe in the air. However, in this area where the clot is, there's no more a gas exchange. It will become a dead space. Okay? So you will expect that the person's oxygen level will drop considerably. Okay? Even though if you are giving them high flow oxygen, if the clot is still there, yeah, it will not resolve. Okay? So most often, in the case of the PE, they're going to end up being intubated if they're not going to respond to the high flow oxygen or the mask and the non-rebreather. But even though we still have to go through with those oxygenation modalities, right? But still, they're going to end up to be intubated. It's because of the severity of the pulmonary embolism that is really causing a huge issue into a particular portion of the lung lobe. And yeah, that's pretty much it. We will be going over some more of the questions tomorrow, and I will select some more SATA questions instead of just the multiple choices because they're easy to answer. I want to make sure that you will be exercised with the learning that you have gained in the past few days. So yeah, expect to do some more Q&A tomorrow and the following day. So I appreciate your time, guys. Thank you for your attendance today, and I will see you same time at 9 p.m. Eastern time. All right. Thank you, guys. You take care.